Welcome, everyone, to the latest installment of EMS Focus, a collaborative federal webinar series. My name is Kathy Gottschall, and I'm the Senior Health Scientist at the Office of EMS at NHTSA. Together with our federal partners, NHTSA's Office of EMS is focused on advancing a national vision for emergency medical services. The projects we undertake and the resulting resources these projects produce for the community help to support EMS systems improvement, measure the health of EMS systems nationwide, and we deliver the data that EMS leaders need to advance their individual EMS systems. Another role of the Office of EMS is to educate the EMS community on new innovations, processes, and technologies that can help to provide better and more efficient patient care. This free webinar series, hosted by the NHTSA Office of EMS, is a unique opportunity for federal EMS agencies to share information with the EMS community in a manner that is more personal and less time-consuming than attending a conference, and offers the community the opportunity to interact and ask questions, opportunities that a newsletter or journal article just don't allow. EMS Focus conducts webinars several times throughout the year on issues that are important to the EMS community and provides you with timely information on how federal agencies are responding. Today's webinar is being recorded and will be archived on ems.gov for future viewing and listening. Additional information on the EMS Focus webinar series can be found on ems.gov. Next slide. Today, we'll be talking about a recent report on trauma care in the U.S. And describing for you a variety of efforts underway to create a national trauma care system that would reduce the number of deaths from injury on the highways, on the battlefields, and in any setting. Trauma remains a leading cause of death in the United States, despite advances in pre-hospital and in-hospital care over the last half-century. With its role in injury prevention and emergency response, EMS plays a key role in achieving the goal of saving every savable patient with traumatic injuries. Next slide. Next slide, please. Okay, in today's webinar, we'll learn about the latest national statistics and findings on trauma in the United States and what NHTSA and the Office of EMS are doing to support the role of EMS and first responders in saving the lives of people with traumatic injuries. We'll also hear about new findings and collaborative efforts from the American College of Surgeons Committee on Trauma and lessons learned from the U.S. military for use by civilians, law enforcement, and first responders. Finally, we'll examine recommendations from the latest report on a national trauma care system published by the National Academies of Sciences, Engineering, and Medicine. And we'll learn what you, the EMS community, can do to help achieve the national goal of zero preventable deaths after injury. Next slide, please. We have a great panel of speakers today who will share with you their work on improving trauma care and their vision for creating a national trauma care system. Dr. Ronald Stewart graduated from medical school and completed his surgical residency at the University of Texas Health Science Center at San Antonio. He then completed a trauma and surgical critical care fellowship at the University of Tennessee Health Science Center in Memphis. Over the past 3 decades, he has actively led the development of an integrated civilian military trauma system that serves all of South Texas, covering more than 26,000 square miles. For the past 20 years, he has served on the American College of Surgeons Committee on Trauma and currently serves as the national chair of that committee. Dr. Holcomb received his MD from the University of Arkansas Medical School in 1985 and entered the U.S. Army. He completed his general surgery training in 1991 and then deployed with the Joint Special Operations Command for the next decade. Over the years, he has been deployed in numerous combat theaters around the world and has served for more than 15 years as a member of the Committee on Tactical Combat Casualty Care, which develops guidelines for the care of U.S. military personnel. He has retired from active duty and has been professor of surgery at UT Health in Houston, Texas since 2008. And I am Kathy Gottschall, your moderator for today's EMS Focus webinar and the Senior Health Scientist with the NHTSA Office of EMS. I have a doctoral degree in public health from Johns Hopkins, and I've published more than 40 articles on trauma care and injury severity scoring in peer-reviewed journals and medical textbooks. Here at NHTSA, I focus on supporting the development, implementation, and evaluation of evidence-based guidelines for pre-hospital care and providing public policy advice on a wide range of topics from trauma research and pre-hospital care to older driver safety. I'm happy to be serving as your moderator today. Next slide, please. I'd like to kick off the presentation by sharing recent national level data and research at NHTSA to improve trauma care for all injured roadway users. And I'll talk about parts of NHTSA's strategic plan to improve survivability from crash-related injuries. The following statistics come from various studies and databases, including the National Trauma Care System report released by the National Academies of Sciences, Engineering, and Medicine, which is a mouthful. It's also known as the NASEM or NASEM. And Dr. Holcomb will be discussing this in greater detail later on. Also data from NHTSA's Fatality Analysis Reporting System, also known as FARS, and NHTSA's National Automotive Sampling System, Crashworthiness Data System. And finally, the study by McKenzie and others comparing outcomes for patients treated at level 1 trauma centers to those treated at non-trauma centers. The latest data show that 35,092 people died in traffic crashes on our nation's roadways in 2015. This averages to 96 deaths per day, or 4 every hour. In this context, the NASEM report estimates that approximately 20% of all trauma deaths could be prevented with optimal emergency and trauma care. Next slide. NHTSA data show that more than 1/3 of persons seriously injured in motor vehicle crashes are not taken to a level 1 or level 2 trauma center, even though NASEM estimates that more than 80% of Americans live within 1 hour by ground or air transport time to one of these centers. Evidence also shows that someone injured in a motor vehicle crash has a better chance of survival if they are taken to a level 1 or level 2 trauma center, but they don't always get there. NHTSA and the Office of EMS are looking at this as an opportunity to save lives in a variety of ways by transporting more severely injured trauma victims directly to a level 1 or level 2 trauma center, by implementing evidence-based guidelines for trauma care, and by supporting the development of a national trauma care system. Next slide, please. Earlier this year, Dr. John Kramer, director of NHTSA's Office of EMS, wrote a letter to Chris Murphy, the regional administrator for NHTSA, sharing this national data on trauma. He shared that according to FARS, 42% of all motor vehicle crash fatalities in 2015 occurred after the victim arrived at the hospital. From this database, we don't know how many of these nearly 15,000 victims were treated at a trauma center, but while not every one of them could have been saved, there is a great opportunity to improve trauma care and prevent fatalities. An important piece to improving trauma care is improving trauma data. In 2016, state EMS officials began transitioning to version 3 of the National EMS Information System, or NEMSIS, which will allow data to be gathered on the number of patients transported by EMS to all levels of trauma centers, a vital piece of information to improve systems of care for those injured in motor vehicle crashes and with other traumatic injuries. Next slide, please. The adoption of NEMSIS version 3 is one of 7 countermeasures that we at NHTSA's Office of EMS have identified as things that we can do to support improved trauma care for all crash victims. The other EMS countermeasures are listed here and relate to ensuring that we support the integration of the best science available into patient care guidelines. Each of us at the local, state, and federal levels has an important role to play in improving trauma care within a framework of a national trauma care system. It's important that each of us ask and answer the question, what is my role? What can I, my agency, my hospital, my region, or my state do to improve the delivery of trauma care and achieve the national goal of 0 preventable deaths after trauma? Next slide, please. The road ahead is NHTSA's strategic plan for the years 2016 to 2020. It includes 5 strategic goals and accompanying objectives and tactics. EMS has a primary role in NHTSA's strategic objective for crash survivability. In the next 4 years, NHTSA is committed to saving an additional 500 lives by enhancing crash recognition, response, and emergency medical care. NHTSA has worked in close collaboration with the American College of Surgeons for many years to share information about the latest work of the ACS Committee on Trauma, as well as the collaboration among the ACS, NHTSA, and the Department of Defense on the role of EMS. I'd like to pass the baton to my friend and colleague, Dr. Ronald Stewart. Ronnie?
Thank you. Thank you, Dr. Gottschall. It is an honor and a pleasure to be on this webinar with you and Dr. Holcomb and with our NHTSA partners, which are absolutely critical to getting to 0 preventable deaths. Next slide, please. So I'm going to talk about the National Academy's report and about specifically how best to implement the Academy's report. There have been at least 6, 7 reports since the original 1966 report. And so our goal with the Committee on Trauma is to get this implemented, but this is not a Committee on Trauma program alone. It involves all the organizations on this slide: NAMT, NAMESP, NHTSA, the larger American College of Surgeons, the American College of Emergency Physicians, Trauma Centers of America, the Department of Defense, and the American Association of Surgery or Trauma, the National Trauma Institute, East and West. It is really a team effort that's required to get this implemented. Next slide. So a little bit about the history before we get going. The first white paper on this was the 1966 National Academies of Science white paper. The 2016 report was released almost exactly 50 years after that original report in 1966. In ways very similar to the 66 report, the 2016 report is a mixture of military and civilian physicians and scientists, really with their experience gained from extended combat experience. The people to the left of this slide are Dr. Sam Seeley, Dr. Alan Thal, and John Howard, and the surgeons on the involved with the project to the right. Special call out, shout out to Dr. Norm McSwain, who died during the report. And one of our panelists, Dr. John Holcomb, was one of the developers of the report. Next slide. So the report is comprehensive in scope. There's 11 summary recommendations. It's about 450 pages long. But I can summarize it by saying that the report calls for zero preventable deaths and disability after trauma, and working towards one nation, one system. The committee initially started working on how to optimize the military system, but realized that really the military and civilian systems can be optimized together or not at all. Next slide. The Committee on Trauma has published 2 position statements advocating for the report, advocating for implementing the report, one with the COT alone and one with a group of partners. Next slide. Again, working with NHTSA, working with the other partners of the report, we've convened as a multidisciplinary group of providers to get together on 2 separate occasions to plan implementation strategies. Next slide, please. The first recommendation is the most important. The White House should set a national aim of achieving zero preventable deaths after injury and minimizing trauma-related disability. Next slide, please, or advance the slide, should have something pop up. So we call that getting towards trauma, zero preventable deaths and disability. The hashtag on Twitter is #TraumaZPDD. This goal has, it seems, and it is a lofty goal. It's a goal worth fighting for, though. It's a goal that is worth achieving. And it is doable in small groups. The 75th Ranger Regiment demonstrated that achieving zero preventable deaths is an achievable goal. So our aim and the principal goal of this report is to get to zero preventable deaths and disability after injury. Another way to frame that, if you would like to frame it differently, would be to make certain that all survivable injuries survive. Next slide. So how to get there? Well, how do you take a 40, 50-page document and make it implementable? Well, the group working together has come up with a plan to break it down into manageable and relatable areas, to work towards a way to communicate this to policymakers and to the public. This communication strategy should be naturally organizing and aligning. It should basically encompass the whole project, be centered on the best interests of our patients, and describe a path for getting to zero preventable deaths and disability. To do this requires a big tent. It requires us working together as a trauma EMS community in a civil, collegial, and inclusive way to make this happen. I will say this, in working with this project for at least the past year, that advocacy is going to be key. We must take action from an advocacy point of view, because if we do nothing, it favors inactivity, which is the status quo. Next slide. The way the COT would normally approach any problem is based on 4 pillars: education, improving quality patient care, developing trauma systems, and advocacy. So the COT, left to its own devices, would attack this problem in that way, and the COT is working on this way, but we have a little bit of a different slant with respect to this, working with the multidisciplinary group. Next slide. We've broken it down into 5 broad domains. One is trauma system, implementing a trauma system, the basic infrastructure and organization of that system. 2, working on trauma-related research and research funding to increase the quality and quantity of trauma-related research. 3, to improve the trauma data and data linkage. 4, to work on the trauma workforce, both military and civilian, with respect to education, training, and readiness, with advocacy as an overarching umbrella to make all of these things happen. Again, this cannot be done alone. It can be done with a lot of people working together in the greater trauma community. Next slide. The second meeting we had was held on the NIH campus, and it's okay. It was held on, you can leave the slide there. It was held on the NIH campus. There were about 169 attendees. About half were physicians, half were not physicians, and about a quarter were COT members. So what is the problem, though? Dr. Gottschall alluded to it. She talked about it from a traffic point of view. But I'm gonna talk about the trauma problem as a pie. There's more deaths in children from trauma than all other causes combined. And if you look at disability, it's the same. This is the most pressing problem for our children. More than 130,000 Americans die every single year. The healthcare costs are approximately $100 billion. When you add in lost productivity and other costs related to the trauma, it's $671 billion per year. This is the most important problem of our children and our uniformed service personnel who we count on for putting their lives at risk for us in times of conflict. This is still the most pressing and neglected public health problem in the U.S. Next slide. Much progress has been made. Much progress has been made in the past 50 years. Next slide, please. Dramatic improvements in both care and prevention. Entire professional disciplines have been established in the past 50 years. At the beginning in 1966, much of EMS, it wasn't really called EMS, was run by funeral homes. The disciplines of emergency medicine, trauma nursing, trauma surgery have all really grown and flourished during that time. There have been radical improvements in quality. In spite of lack of funding, research and scholarship have actually flourished, both from the EMS side, from the hospital side, and rehabilitation reintegration. Data systems exist today to determine outcomes that would be simply unimaginable in 1966. There's been an educational transformation around trauma care, both in the pre-hospital world, the hospital world, and the post-hospital world. These have resulted in major reductions in mortality and complications. So I want to make it clear that in spite of all the work we have to do, much has improved in the past 50 years. Next slide. But what are these problems? The 4 problems that I laid, the 4 problems there is trauma system infrastructure. The trauma system is still a patchwork quilt with major access gaps shown in red on this slide, but actually true overproliferation in other areas where trauma centers are stacked on top of each other. So getting to a more effective trauma system is key. Next slide. Research and research support. There's a lack of research funding for trauma and acute care. If you look at the burden of the disease, it is absolutely dead last with respect to federal funding. The lone exception for this might be the Department of Defense, but even Department of Defense funding is dispersed across other core areas. So funding for research is key. Next slide. In his presidential address to the Southern Surgical, James Thompson, the late James Thompson, basically made the point that unless we invest in medical education research like seed corn, the Bible, we were admonished to lay corn for the land would not perish through famine. So if we fail to invest in research, we will have a medical famine. Next slide. So Dr. Eileen Bolger has led this in many ways. with respect to, in addition to coming up with a National Trauma Action Plan, to come up with a National Trauma Research Action Plan, to advocate, to define what the need is, to look for a federal home, and develop a unified overarching approach to advocacy. Next slide. To quote her, advocacy, advocacy, advocacy. We must push for research funding. It must be thought of as a part of a trauma system. I'll lay out that picture to you in just a few minutes, but it is a key part of having an effective trauma system. Next slide. The third area is data gaps. We need improved data linkage from the scene to the hospital and beyond. There are two big data gaps, both at the temporal extremes. Those who die in the field, as you know, many people die in the field before EMS arrives, but those who don't make it to the hospital do not get put into hospital databases. And the other big data gap are long-term outcomes after patients are discharged from the hospital. These are two big data gaps that we need to make improvements. Next slide. In the fourth broad, or with the trauma continuum, if you think about the data gap, press the advance button, please. As the patient goes from scene to EMS to initial care to EMS to definitive trauma, inpatient rehab, and 1 year post-discharge, to paint a picture of the entire system, we need data from all of these elements. Next slide. The last area, the fourth area we talked about besides advocacy is workforce. In the military world, there tends to be lessons lost between conflicts. And military battlefield lessons learned during times of conflict are often not reliably translated to civilian care. So, and also going back the other way, during interim gaps or even during times of war, civilian advances may not be reliably translated to military care. So integrating and developing the military and civilian workforce, both pre-hospital and hospital, is a key to getting to zero preventable deaths and disability. Next slide. So the solution for this is to integrate the civilian and military trauma systems, to develop military centers that function as trauma systems. I happen to work in such an environment where we have a fully integrated military trauma center that takes care of civilian patients and is fully integrated into our civilian trauma system. The other way to do this, though, is to put military providers in civilian hospitals, busy trauma centers, but also hospitals that may do a lot of acute care surgery as well. Next slide. So we need a national trauma action plan. How to get to zero preventable deaths? Well, to get to zero preventable deaths, we need a great trauma system. We can't have a great trauma system without great research. We can't have great research without great data. And we can't implement a great trauma system without great education and training. We absolutely need a national trauma action plan. Next slide. We also need to engage trauma survivors. We had a great speaker at the last multidisciplinary conference, Peter Thomas. Mr. Thomas is an advocate, he's an attorney, he's a leader, and he's a trauma survivor. By involving trauma survivors, we can improve our advocacy and we can improve patient care by involving people who can relate to the patients who've been severely injured. It's a key step. Next slide. The time is now. The time is now. I know that politically we live in tumultuous times. I know the degree of disagreement, but 1966 was also a time of turmoil. It's been 50 years since the first true great strides were made in improving trauma care. We have two reports that are almost mirrors of each other that paint a roadmap to how to get there. Even though we live in turbulent times, we have aligned civilian and military leaders. We have a committed group of young and senior leaders, both pre-hospital, hospital, and post-hospital. We have an organized commitment from multiple different medical organizations, and we still have a critical need with a large burden of disease. This problem is critical for both national and homeland security. It's critical for our children. And pre-hospital care and EMS are absolutely critical to getting to zero preventable deaths and disability after trauma. Next slide. Thank you very much.
Okay, Ronnie, thank you very much. Kathy, appreciate the opportunity to be here. This is John Holcomb. I'm a retired, as Kathy said, a retired colonel in the military, and then I've been in Houston as a civilian surgeon for the last 8 or 9 years. Next slide. So lessons learned from Iraq and Afghanistan and how they translate into the civilian world, and as Ronnie suggested, kind of going back and forth is a great topic. At the beginning of the Iraq War and Afghanistan, 2001 and 2003, we had the military had no trauma system, no registry, no tourniquets, no real charts, no communication between the levels of care, no performance improvement, and no research in theater. Other than that, things were pretty good. And starting in 2004, we really worked very hard, a large group of people in conjunction with our civilian trauma colleagues, and leveraging, as Ronnie said, that relationship in San Antonio where the military and civilian guys had worked together for a long time to really address all of these and make things better. Next slide. You go back a little bit farther, pre-hospital, now talking pre-hospital battlefield trauma care. After our experiences in Somalia in 1993, we started really taking a look at these things and said, you know, the trauma courses that are taught are not developed for combat, which is different than civilian care. There was no tactical context for care under fire, and then using terrain features. Heavy emphasis on intratracheal intubation versus bleeding control. Very different. We have the majority of patients on the battlefield suffering from penetrating injury rather than blunt motor vehicle crashes. Our medics were taught, and the entire medical system was taught not to use tourniquets. No hemostatic agents. Gauze had been used for millennia. No junctional tourniquets for the injuries in the axilla and the groin. The soft medics, special operations medics, were taught IV cut downs when they had difficult venous access. 2 large bore IVs with large amount of crystalloids was standard of care. And IM morphine, Civil War vintage technology, and no focus on prevention of hypothermia and coagulopathy. So that was really the state of pre-hospital care in 1992, pre-Somalia, and then extended all the way up to Afghanistan and Iraq. Next slide. If you move forward to now and compare the previous slide to this one, we have phases of care, and tactical combat casualty care, reflecting the reality of providing care in the middle of a firefight or immediately afterwards. We aggressively use tourniquets and have saved hundreds, if not thousands, of lives. Combat gauze as a hemostatic agent is used. It's an active agent instead of a passive gauze. Needle thoracostomy is widely employed for tension pneumothorax, a third leading cause of death on the battlefield. Instead of tying people down to backboards, we allow them to sit up and lead forward for appropriate airway positioning after penetrating injury. Surgical airways are needed for significant facial trauma, unfortunately something that happens pretty frequently. Hypotensive resuscitation, or not raising the blood pressure back up to, quote, normal when you have uncontrolled truncal hemorrhage, is widely employed. The resuscitative fluid of choice or blood products rather than crystalloid. IVs only when absolutely needed, and patients who do need them and are hypotensive, as everybody knows, those IVs are difficult to start, so intraosseous is widely employed. Instead of morphine, which has great hemodynamic effects, triple option analgesia is widely used, which provides optimal pain control without hemodynamic compromise. And we really pay attention to hypothermia and coagulopathy, antibiotics, and junctional tourniquets. So huge differences over the last decade in just about every facet of what we do on the battlefield and the pre-hospital, which rolls into the hospital environment. Next slide. How do we translate that into Houston? Well, we put tourniquets on helicopters in the emergency department in 2008, followed quickly with tourniquets on all 600 ambulances in the greater Houston area. Tourniquets and hemostatic dressings for 5,000 police officers soon followed. Resuscitation fluid switched from crystalloid or no resuscitation to plasma and red cells on helicopters. Initiated a preventable death study of all 1,800 trauma deaths from 2014 in the greater Houston area. Houston's an interesting place with an 85% autopsy rate for all trauma deaths, so it allows us to really look at that preventable death rate from a regional point of view. The Stop the Bleed program has been a really big emphasis in this area, promulgated by the American College of Surgeons and others through the Hartford Consensus, endorsed by the White House. We'll talk about that in just a minute. And then, interestingly, we should have whole blood available in several pre-hospital EMS ground units potentially next week as we roll into the 4th of July weekend. So really taking those lessons learned and applying them in the greater Houston area at multiple levels in the pre-hospital environment. Next slide. As Ronnie said, the NASEM report was, I think it provides a wonderful roadmap for what to do. Obviously that report, although it's 500 pages, can't tell us how to do it, but it does lay out a roadmap and broken up into different parts. Next slide. The report goes into who would benefit most from a national trauma system. Well, and as Ronnie and Kathy have laid out numbers, the numbers are important. The U.S. military, approximately 1,000 potentially preventable deaths from combat trauma, probably a little bit more now as we unfortunately see some more casualties happening. In the civilian sector, that number is dramatically greater. So during the same time where there's been 1,000 potentially preventable deaths, probably close to 200,000 potentially preventable deaths or even more in the civilian world as we kind of look across the United States. Huge implications, as Ronnie said, for us today and for our children in the future. Next slide. Tactical combat casualty care is that type of care really developed by Dr. Frank Butler and many others on that committee that's been meeting now for almost 20 years that has led this change in care on the battlefield, and then spreading into tactical EMS and other areas of the civilian community. Next slide. What can TC3 offer to civilian EMS systems? Well, really those hard-won lessons from the battlefield, especially appropriate not only for everyday trauma, but of course for mass casualties and active shooter events. The number one, I think, focus of TC3 is stopping bleeding by many different methods, both whether it's extremity or truncal bleeding, with a trauma airway approach that makes sense based upon the injury pattern, needle decompression for tension pneumothorax, and then hypotensive resuscitation with blood products, things that we've already talked about. Next slide. The National Pre-Hospital Trauma Care System really needs to start not only with the medics, but everybody else who might, quote, be in that area of interest. And we learned this lesson on the battlefield. It sounds pretty obvious, but when we put tourniquets in the hands of medics, it had an effect on the battlefield in Afghanistan and Iraq. But when we took tourniquets in the hands of every soldier, sailor, and airman, Marine, special operator on the battlefield, is when we really saw a dramatic reduction. That corollary are, of course, teachers and school officials, just about anybody that works anywhere where there might be injuries, and of course that includes everybody. And then, of course, the professional first responders are law enforcement officers, fire and EMS personnel, and tactical medics. Next slide. Standards of care are important. Much like we have burn life support and cardiac life support, we should have trauma life support. Both for laypersons, the law enforcement officers, fire and rescue, EMS personnel, in a layered approach, with each group being a little bit more capable and have a little bit more equipment than the others, but mixing and matching based upon the local resources and local opportunities to care. This is going to make trauma training the equivalent of BLS or CPR across the country, and I think will have great effect on lives saved. Next slide. What can you do is go to that NASEM report, and as Ronnie said, it's 518 pages, but there's a shorter version that you can download, the Cliff Notes versions, if you will. Get involved, work with your trauma system, drive innovations with data, and share results. And I think we've all kind of said the same thing. I just would end with share your preventable deaths, share your performance improvement, share your lessons learned amongst agencies, and then that allows us to keep that focus on the patient, both the one that we have in front of them and of us in front of us right now, and the one that may be in front of us tomorrow. Thank you very much.
Thank you so much, Dr. Stewart and Dr. Holcomb. I'm happy to say we've got some time for questions, and we have some really interesting questions coming in from our viewers and listeners. I'd like to start out with a question we just got to ask. Has anyone clearly defined preventable death, or is this still open to subjective opinion? Doctor, I'll leave that to you.
John, you want to take
Ronnie.
that up?
Oh, yeah, I'll take it. So preventable death is interesting. We did a series of studies in the military, starting with 14 patients and ending up with several thousand. And frankly, Kathy developed that definition, which is a little subjective, over the course of those 3 published studies. I would say that this, when unfortunately, it sounds a little gruesome when people have missing parts of their trunk, or missing the abdomen, or missing their head. That's a non-preventable death. I'm not going to do much about that. And then you go all the way to the extreme of a patient who falls down and has a fractured spleen and bleeds to death from the splenic injury. Well, if you can get them to an operating table, that's a potentially preventable death. So there's, of course, you have the issues of weather and transport, finding people and getting them, et cetera, et cetera. So I say there's some areas that are very clear, others that are a bit less clear. You have the issues of transport, finding people, getting them into the operating table, on and on and on. But it is a little unclear, but it's really useful. I think this is one of the main lessons learned out of the military that we try to put into the report from the NASEM report, is that this concept of potentially preventable and preventable death drove innovation on the battlefield. It absolutely drove innovation with data on the battlefield in the areas of tourniquets and hemorrhage control, needle decompression, with near immediate results. I would assume that on the national level, regional level, local level, and the national level in the United States, it would do the same thing. Ronnie, thoughts?
And I'll just piggyback on top just a little bit. I totally agree with Dr. Holcomb. I would refer the questioner to for the papers in theater by Brian Eastridge and colleagues to look at definitions, but there is some ambiguity. Sometimes there's no ambiguity with respect to it. A lot of the when we talk about preventable death from a trauma system point of view, it deals with lack of full coverage for EMS not as an essential service, not being available, not being found. There's many system issues. In the same group, Dr. Eastridge, along with Dr. Holcomb on the study as well, is a group of looking at working with in 4 or 5 different areas of the country, looking at better defining a preventable death.
And just chiming in the National Academy of Sciences, Engineering, and Medicine report, they define preventable death as those casualties whose lives could have been saved by appropriate and timely medical care, irrespective of tactical, logistical, or environmental issues. So there are both subjective and objective answers to the question. We have another question coming in. It says, I have been yelled at for bringing a patient to a trauma center and activating a trauma team for a patient whose injuries didn't end up needing those resources. How can we avoid under-triaging and preventable deaths, yet at the same time not over-triage and drive up costs for the patients in the system?
Go ahead, Ronnie.
Holcomb and Stewart?
I'll take a stab at that. Kathy. Well, first of all, I would say I'm going to apologize for anyone being yelled at. Of course, any triage decision is based on probability, so there's uncertainty always in the decision. And really, I never let somebody who may just be having a bad day basically ruin my day if I'm doing the right thing. So I think EMS professionals should take the patient to the hospital based on their own agency's triage guidelines, working within their trauma system to come up with what works best in a local region based on national guidelines. And so those conversations are always best had within the trauma system itself, where pre-hospital professionals meet with hospital professionals, both emergency medicine physicians, nurses, and surgeons, to come up with the optimal triage criteria in a given region. And there's always going to be some inaccuracy with the process because it's based on probability.
Kathy, can I just add, it's always better to over-triage than under-triage from a patient point of view. From a patient point of view, over-triage is better than under-triage. If someone was yelling at me, I would not lose. I wouldn't bother me one little bit.
Thank you, doctors. Another question. Do you foresee shifts in funding for trauma research in the near future? Alternatively, do you see the Department of Defense being more open to more civilian-focused trauma research, blunt trauma, rather than solely battlefield trauma, that is penetrating trauma?
I'll take the first stab, and then Dr. Holcomb, feel free to follow up. I believe if we work together as a trauma community, as a large umbrella trauma community that involves the pre-hospital community, the public health community, the trauma surgeon community, the emergency medicine community, that I believe if we work together, we can achieve improved funding for trauma-related research. It is going to take us working together and clearly advocating for it. It is not going to happen on its own, but I believe we can make that happen. With respect to the DoD part of the question, I do think the Academy's report talks about this and suggests that it's not just penetrating trauma, it's blunt trauma, penetrating trauma, trauma from all causes, and I believe that there will be continued and hopefully increased funding from the DoD for those causes. Dr. Holcomb? Yeah,
Ronnie, thank you. The DoD, it's interesting, on the battlefield, in the midst of a firefight, many of the injuries are penetrating injuries. There's a lot of blunt injuries on a battlefield with the trucks and tanks, et cetera, that's flying around all over the place. And the studies that the DoD has funded back in the United States include both penetrating and blunt injuries almost always. In fact, some of the head injury studies exclude penetrating injuries, and the ones that we've been associated with have anywhere from 50 to 80% blunt injuries. So I think at least right now the DoD is funding injuries on the civilian world that reflect what goes on in the civilian world. But the penetrating focus, of course, is understandable for what happens on the battlefield.
Okay, great. We have another question. Excuse me, I just lost it. It says, what can individual state trauma systems do to support this effort?
They can come together, discuss the report, be knowledgeable about the report, work within their communities, their regions, and their states, and work as part of a multidisciplinary team to make these recommendations, not just recommendations that sit on a coffee table, but recommendations that turn into reality. And a lot of this can be done at the state or regional level. even though I think coming together as a national framework and national trauma system is key. Working together as a greater community is what those trauma systems do best. My experience from an advocacy point of view is when pre-hospital professionals, paramedics, nurses, physicians, hospitals, when we show up together advocating for the same thing, it is like motherhood and apple pie, and it's very hard not to fund those things. So we're better when we work together. Over.
Thank you, Dr. Stewart. We have a question. Is there any role for telemedicine or other technologies to help EMS providers triage patients appropriately?
There are some apps that are involved. There's some innovation in the pre-hospital sphere, in the hospital sphere, to communicate information back and forth. I would guess there's regions all across the United States who are piloting those things. Of course, there's routine dispatch communications, and there is a role for those technologies. Some of those would be in exploration, and some of those actually need better research to tell whether they're effective, thus the need for research funding.
Great. I'm going to kind of collapse a couple of questions here. And other questions regarding staffing for EMS, having a paramedic plus an EMT, 2 EMTs, or other staffing levels. Do you guys, from a systems point of view, can you provide any advice on staffing levels within an EMS response unit?
Kathy, this is John. I can respond for kind of how we do things in Houston. It's a very much a layered approach. I think there's a lot. There are about 30 million injured people in the United States every year, with 150 or 140,000 deaths. So I would say the vast majority of trauma patients are not seriously injured, but the ones that are really need a lot of help. Thus, the layered approach with different skill levels, education levels, and bringing different levels of intervention. Of course, always keeping in mind that time is so critically important in these patients who have cerebral, vascular, and truncal injuries. So I don't see any one model working for everybody. Mixing and matching based upon local resources, injury patterns, distances, types of vehicles that are used, etc. It makes a lot of sense to me.
Okay, this has been a really lively and engaged discussion. We only have time for one more question. That is, do you feel the CDC's most recent trauma triage guidelines are up to date with what the U.S. military has taught us?
Well, that's a loaded question, huh, Kathy? Thank you very much.
You're welcome.
I think the guidelines that come out of our national organizations are almost by definition a little bit behind, because there's a very thorough, deliberate process to deliver those guidelines. And then the U.S. military right now is trying to update their guidelines on a monthly or quarterly basis, depending upon what happens on the battlefield with different injury patterns in different locations. So I think almost by design, they're a little bit different, and I think that's probably okay.
Okay, great. We're just about out of time. I want to thank everyone who submitted questions and apologize to those whose excellent questions we didn't have time to get to today. And I want to remind everyone that, that this webinar will be archived, and that the recording and slide deck will be available in the next few weeks on ems.gov. So thanks to everyone for attending today. Thanks especially to our panelists, Dr. Holcomb and Dr. Stewart. With that, thank you so much, everyone. We'll see you next time.
Thank you, Dr.
Bye-bye.
Holcomb.
Take care.
You bet. Thanks, everyone. Bye-bye.